Good afternoon, everyone, and thank you for taking this part of your Sunday to be with us on Black Health Trust. And I would like to turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Walks, and we have an exciting, interesting afternoon planned for you to discuss something that's extremely important. And there are so many things that are extremely important, but this one gets to the heart of the matter. And we're going to discuss in a different format. I'm going to present two cases. We've got actually one patient on with us who's going to briefly present her medical issue. And I'm going to present a medical issue, and then I'm going to ask our discussant to comment on those. But our topic today is heart disease, especially in African Americans, and how to prevent it or mitigate the consequences. I'm going to ask Dr. Williams to start off our program with a statement, but I'm going to introduce him first. I met him when I was about 5 years old. At that time, he was an associate dean of the College of Medicine at Harvard University.
I'd like to throw a flag, point of personal privilege. Dr. Williams was not at Harvard when you were 5 years old.
Thank you very much, Dr. Waltz.
Let me have some fun if I want to. Come on.
All right.
He's my teacher. He's my mentor, and that's for true. He actually gave me my first opportunity to publish by allowing me to write a chapter in his book called Black-Related Diseases. Dr. Williams is full clinical professor at UCLA at the Geffen School of Medicine. He has been to a number of medical institutions, including Downstate Medical Center, Harvard University, and he is the founder of the Association of Black Cardiologists, which is very prominent in our country. More importantly, he's one of the first Black physicians to be a full member and fellow of the American College of Cardiology, and one of the few contemporary people I know to receive an honorary Doctor of Science degree. He has authored some 9 books, 2 of which are in the African American Museum of History in Washington, D.C. And I am very honored that he agreed to be with us today, and I'm going to call on him for a brief statement before we introduce the topic. Dr. Richard Allen Williams.
Thank you very much, Dr. Maxey, and good afternoon, everyone. It's nice to be invited to such an auspicious program as this, and I'm very happy to be on. I'm going to just give a little preface to my presentation, which will be on cardiology, especially issues that pertain to the Black population. I was born in 1936. Sounds like a long time ago. And the reason I bring that up is because 1936 was a good year for several occasions, one of which was Jesse Owens's performance in the 1906 Berlin Olympics, in which he set like about 5 world records in one day. And also the fact that that was at the height of the Depression, the Great Depression, which was occurring, as well as the fact that it was obviously a good year for pretty babies.
Absolutely.
And one bad thing, though, that happened during that year, 1936, is that a gentleman, a cardiologist named Dr. Weiss, published an article in a peer-reviewed medical journal, which criticized not only Black intelligence, but the ability of Black people to even recognize if they got legitimate chest pain, which was something that heralded the presence of coronary heart disease. He specifically said that Black people didn't have the intelligence to recognize the symptom of chest pain as being significant. And in any event, that's in the a peer-reviewed journal, which I can document. And I wanted to point that out because of the fact that at that time, we had no Black cardiologists. We had very little knowledge about cardiac disease in Blacks and not very much concern about it. If Black people were found to have any heart disease at all, it was attributed to syphilis and tuberculosis. And we weren't thought of being worthy of being considered as important people to be treated or diagnosed with heart disease. So I wanted to start out with that to give a perspective as to why we are concerned about heart disease in Blacks today, and the fact that we have over the years taken control of our own destiny in regards to taking a look at this whole situation. Dr. Maxey mentioned that I was a founder of the Association of Black Cardiologists, which almost 50 years ago took issue with many of the concerns or lack of concern about heart health in Blacks. And today we recognize the fact that unfortunately Black people have more heart disease of various types than anybody else in our society and in the world, in fact. And so I wanted to use that as a preface to what we're going to be talking about today. And I'll turn it over to Dr. Maxey to take it from there.
Well, thank you. Dr. Williams, I'm going to ask your indulgence. I'm going to present two cases. One with a young lady who is a good friend of mine and happens to work in my office as my medical assistant. And she wants to talk about what happened to her, and I'd like you to comment on. Then I have one more. I'm going to introduce Miss Ashana Porter, and I'm going to let her tell her story so I don't steal her thunder. Miss Ashana Porter, would you briefly give us just your history and a little bit about you?
Yes. I was working for Dr. Maxey he hired me in the medical field back in 1993. And
you didn't say 1936.
No. No. And he gave me that start as far as the medical field and things like that. I was young. I was only 28 years old. I had my daughter at 29 on January 2nd of 1994. I was a young, healthy, vibrant young woman, okay? And had my daughter January 2nd of 1994, developed gestational diabetes. Dr. Emmanuel Umba was my doctor at the time, great gynecologist, OBGYN, and he followed me. I had complications during my pregnancy though. And after giving birth to my daughter, we didn't realize that it had tore the muscles down in my heart until after the fact. So once I gave birth to her, I started feeling like really tired and sluggish and things like that. But I only thought that it was because I just had a baby. I'm new to motherhood. I'm married. I got a home. I'm trying to keep up all these different things. I'm working. So I go back to work. I'm thinking things are okay. At the time, it was Associated Primary Care. So we had a lot of doctors that were in-house with Dr. Maxey, which I'm thankful and grateful for Dr. Maxey that she was doing Associated Primary Care medicine at that time with everybody under one umbrella. Because Dr. Coates, I was able to see, and Dr. Diop was the doctor for my daughter. Okay, Abdoulaye Diop was the doctor for my daughter when I gave birth. However, I had developed a cold and I was like, I don't feel good. So I got a cold or so. So I had taken some Theraflu back then. Theraflu was the instant kind of, you take it, you feel better, get some rest. I did that. However, I still kind of felt tired, but I never said anything about it because I'm like, I'm still thinking I have this baby, I've had a baby and I'm new to motherhood. Maybe it's postpartum depression, all of those type of things I'm thinking. However, I had a cardiac arrest on October 26, 1995 in Dr. Maxey's office. I died in the office. And Dr. Rubin was there to administer CPR to me along with the paramedics. Once I was out, I did not know until I had come back to. I finally came back to, and when I did, from here down, I couldn't feel anything. I didn't know what had happened, and I was asking them what had happened. I just knew I had all the burn marks on my chest where they had tried to keep resuscitating me. They found out that I had postpartum cardiomyopathy, given birth. It's a simple thing like that, just trying to have a baby. And so I had been without oxygen. So what you see now is all God, because I was without oxygen for 15 minutes, the brain, and they had given up on me pretty much. And they had told my family, that's it. You say her goodbyes and things like that, because the only person that can save her at this point, we've done everything medically necessary, was God. During this time, I was Dr. Anthony Reed stepped in and became my cardiologist. I couldn't see, my eyes were all messed up. Dr. Lawrence Goodwin became part of the team. Dr. Ibrahim Helmi they built a team around me, he did all the physiology of the heart, the defibrillator, okay? They implanted a defibrillator on November the 1st because it had to do, the electrical part of my heart was not really beating. I ended up having a 15% ejection fraction. I know nothing about all of this, but now I'm so into the heart that's my world. Okay. I found out that during that time period, now I'm only 30 years old now. Okay. Cause I didn't have my baby. It's almost a year. Nobody talked about Black women having heart problems. None of that. You were healthy. They try to attribute it back to the fact that, oh, you grew up this way. No, healthy eating and all that. However, it was not understood. And Dr. Reed, we went through so much as far as learning and trying to understand. So I thank you, Dr. Williams, for bringing that on early on, because it helped me. It was a total blessing to me because he introduced me to so many different doctors and brought me into the fold of cardiology. And so once I had the cardiac arrest, I resumed. Had many battery changes until the point where they couldn't change out a battery anymore. So we're still thinking that the medicines are going to work, going to strengthen the heart. Instead, it got weaker and weaker and weaker. But I still pushed through no matter what. Okay, and got to the point of 18 years down the line. So Dr. Reed called me in the office and said, we have to do a heart transplant on you. We have to put you on because there's nothing else that we can literally do for you at this point. So I'm like, a heart transplant? What are you talking about? A heart transplant? Not knowing that my heart was severe as it was, the muscles being floppy and stuff, not being able to constrict and keep my beat the right way. And so, I already had a defibrillator. So what else? It had been going out from my chest many times. So every time that defibrillator went off and kicked me in the chest, it also weakened the muscles again. It also did that. So he sent me over directly to Cedars-Sinai Hospital, where Dr. Kabashigawa, Dr. Chang, and Dr. Kittleson were on board at that time. They had transferred from UCLA, and they were doing everything at Cedars-Sinai. That's when they realized that my heart was 3%. And they were like, how are you alive?
Ejection fraction was 3%.
My ejection fraction was 3%, to the point where they just basically keeping me afloat. Okay. I became number 1 on the heart transplant list nationwide. And so they had to literally get me together, get my bodies and stuff together to receive a heart.
Let me ask you this.
Yes.
Now we're in 2023 and you have your heart in, and I'm so proud of you. You've dedicated your life to young kids. You have a football team.
Yeah.
You take care of kids in the neighborhood.
Yes, sir.
Dr. Williams, she is a survivor in spades. And I'm so proud of everything she's doing. And we're
Thank you
just so
very much.
glad that you shared your story here with us.
Yes.
And she is my medical assistant now, currently in the office. And I thank you for that. I just want to also add another case real quick for Dr. Williams and then get him started and let him comment on yours. I have a 75-year-old gentleman who's actually our maintenance man who had been hypotensive, and we thought he was just fluid depleted. Turns out that he went to the Wadsworth VA and he has all the signs of what we call HATTR, which I'm sure you're familiar with, Dr. Williams. And except he's got a restrictive component that if he drinks too much fluid, he gets water in his chest. If he doesn't drink enough fluid, he's constantly hypotensive. So I'm very concerned that is also a potentially deadly disease. I want to ask him to present his case, but love you to comment on Ashana's case. And I'm just so proud of her survival and thanking her for coming here today. Dr. Richard Williams, go ahead.
Well, actually, what I'd like to do is to respond to any questions that you might have or that she might have in regards to this case. It's been diagnosed as postpartum cardiomyopathy. And in a minute, I'm going to give you a little lecture on that particular entity. But let me respond to any questions that you might have regarding what she just presented.
So how is her prognosis now?
Well, I think her prognosis now is great because she has a new heart and beginning. So the old condition is really gone. She's a new person.
Right. You're right. And that's how I feel. You're absolutely right. It's like I started all over again. I got a second life.
Exactly right.
So Doctor, first of all, Shauna, thank you so much for coming and being so open with us about that very important and amazing triumph that you shared. One of the things I'd like you to comment, Dr. Williams, I know that a lot of what happens is the physiology and pathophysiology that Shauna shared with us. She also shared with us that that was only God. And she shared with us a fighting spirit and a full of faith presentation. And I want to know how important that portion of the presentation is when you're dealing with someone who has a cardiac condition. The fact that they're full of faith and full of fight.
You know, so often we get caught up in all of the physiology and the science, so to speak, of a particular condition, and we don't take enough into consideration regarding the spiritual aspects of things and how important one's will is to survive. That's extremely important, and I'm sure that Shauna recognizes that many people will not survive if they don't have the will, especially with a condition like this, which is one of the most severe types of situations that one can imagine.
In consequence with what Dr. Walks was speaking about, I heard a talk that explained the role of faith very well. That faith itself does not do anything, but faith is the bridge by which the Lord God Almighty can come across and cure things. It's that bridge that is required for the healing. And she obviously put a big bridge out there for God to come across.
You know what? I knew that when the doctors are telling you that they can't do anything and they've done anything medically for you, you have to have faith. That's all you have. And you ask God to give them the right things to tell you to do. And between your faith in God and the strength that it takes to do it, you don't have a choice. That's it. That's what you lean to. You lean to God. That's it. And medical will do what it needs to do.
Well, we've had quite a presentation about a fantastic situation, and this young lady has confronted it and conquered it very, very well. I want to talk about some of the aspects of it and give you sort of a formal presentation about what she was confronted with and has conquered. So if I could have my first slide. And as he's putting up the slides, remember, we're talking about cardiac problems in Blacks in general. We're going to kind of cone down on 2 or 3 particular problems, one of which she has presented, and talk about it. So I'm going to frame this in terms of healthcare disparities in cardiovascular disease. And you can see a Black family there, minus the lady of the family, not intentionally. But in any event, this is going to be about heart disease in Blacks in general, but in particular about 2 or 3 special conditions that I want everybody to pay attention to. Next slide, please. Simon, are you able to change?
Just a second, it's trying to load.
Okay. We can go all beyond this. Next slide. And next. Oh. Okay, I think you've got the wrong slide deck, but we'll quickly go through things. Could you continue until I tell you to stop? Oh boy. Keep going. You're going to have to actually fast forward almost to the end of the slide deck. This is not the one that, not the second one that I sent. Is there any possibility for you to change over to the other slide deck?
Let me see how I can do that. I marked them different. Maybe in the transfer, the edits came out.
Well, while you're trying to transfer, the first case that you presented, or Shauna's case, was a case of what we call postpartum or peripartum cardiomyopathy. Let me just mention that cardiomyopathy is one of the several heart diseases that can occur. It literally means heart muscle disease, and it's caused by any kind of condition that would adversely affect the heart muscle. The heart is a muscle and consists of several different parts. The muscle itself is responsible through its squeezing to ejection of the blood from the heart into the general circulation. And the amount of blood that's ejected with each beat is called the ejection fraction.
You'd like to call calling Simon Cooper or T-Mobile.
So generally, the amount of blood is somewhere around 50 to 60% of the total amount of blood that's in the heart that is ejected into the circulation. If it falls below that, especially if it falls below a level of about 45%, the individual is said to be in heart failure because the heart is not able to do its normal job of circulating the blood throughout the body.
Right.
Heart failure occurs and is not remedied, the patient simply dies. So you can imagine how important that is to survival. In Shauna's case, what happened was something that you'll see in some of the slides that are coming up, occurs not unusually in Black women. That is what is called postpartum or peripartum cardiomyopathy. It does predominate in Black women. Usually they're older than Shauna was. Usually they're Black women who get pregnant in their later years between 40 and 50 years of age. And they have multiparity, that is, they've been pregnant several times and multigravidas as well. And sometimes have had twinning occurring in their births. And so in any event, it is a condition which does predominate in Black women. We don't know exactly why that is. And Nigerian women in particular seem to have a greater amount of it. 1 in 100 to 1,000 live births in Nigeria might eventuate in postpartum or peripartum cardiomyopathy. It's called that because of the fact that it occurs within the last month of pregnancy or within about 5 months after delivery.
Mm.
And Shauna, I'm not sure exactly time-wise when yours occurred. Was it 5 or 6 months or more later than that?
It was, well, I had my daughter January of 94, and right after I gave birth, like I said, I started feeling tired.
But how many months after that?
I would say about 5 or 6 months.
5
Yeah.
or 6 months? Okay.
Mhm,
That's
mhm. Because I couldn't do my regular, I'm working, trying to take care of the baby, and I'm home. That should be normal. I'm young. But
Oh,
it
right. Well,
became
one of the earliest symptoms is fatigue, just a
Mhm.
general fatigue, a tiredness, and shortness of breath may occur. There
right.
may be a condition called PND or paroxysmal nocturnal dyspnea. You don't have to worry about those terms, but it's a situation where when you try to go to sleep at night, you find that you get short of breath, especially if you're trying to sleep on, say, 1 pillow or less. And you
Right.
have more pillows
Mhm.
behind you, that
Yeah.
kind of thing. And then sometimes things like palpitations may occur, heart palpitations, which are a signal that cardiac arrhythmias are occurring. And I would hazard to guess that when you had your cardiac arrest, that was probably due to a ventricular tachycardia or ventricular fibrillation.
Yeah.
Which you were shocked out of,
Mhm.
fortunately, because if
Dr.
you hadn't
Williams,
had shocks, yes, sir,
can you show your slide, your screen? We're having problems.
I cannot. Let's go back to the original ones and just
He
keep
said
fast
it's
forwarding
not
while
loading
I'm talking.
properly.
Keep fast forwarding while I'm talking, all the way to the bottom, and then we'll just back up from there. And so I'll continue. What I'm saying is on one of the slides anyway. So in any event, some of the symptoms that are occurring are exactly what you had,
First
that
estimate.
shortness of breath, and I'm sure that you probably had some edema or swelling,
Mhm.
especially of your feet,
Ankles. Yep.
ankles.
Mhm.
So those are symptoms of heart failure. And I'm sure that probably Dr. Reed, who was my former practice partner, by the way, late Dr. Anthony Reed,
Right.
treated you with heart failure medications.
Yes.
And yet, despite that, your ejection fraction continued to fall, and you were eventually given a defibrillator, implanted defibrillator, an ICD.
Mhm.
And that would help to some extent, especially because of the fact that if you developed an arrhythmia like ventricular tachycardia, it would shock your heart back into normal rhythm.
Right.
But as it shocks your heart more and more, it, like you indicated, causes the heart muscle to weaken more.
Right.
And eventually your ejection fraction winnows down further and further, and you get to the point where it's hard to sustain life. And that's when more severe or serious things need to be done
Mhm.
to try to save your life. That's right. Keep going with the slides. Keep right on going. So you had quite an ordeal, and
Yes.
it came to the point where something serious, more serious, had to be done to save your life, and that was heart transplantation.
Mhm.
They hold it right there. Hold the slides there. So I'm going to back up in my conversation for just a moment. You see on the screen cardiomyopathy, and the normal heart, which I'm not going to try to point out too much about, is depicted on the left, and the cardiomyopathic heart is on the right. You can see the arrow showing the enlarged myocardium or heart muscle. That's something that occurs. It can also become dilated, and other things can happen to it. Next slide. Okay, here are the types of cardiomyopathy. I'm not going to dwell on these except to just simply show you that there are a large number of conditions that can affect the heart, leading to this term cardiomyopathy. It can be dilated, hypertrophic or enlarged, ischemic or short of oxygen, arrhythmogenic right ventricular dysplasia, which is a long term saying that the right ventricle is deficient in fibrose and not able to pump properly, can be restricted. It can undergo infiltration with amyloid, which we're going to talk about next. And there's a condition called Takotsubo, which is a Japanese term for what we sometimes call the broken heart syndrome. It can be induced by chemotherapy, such as in women who are undergoing chemo for breast cancer. Can be induced by alcohol. It can be, as we said, tachycardia induced. And finally, there is what we're talking about today, peripartum cardiomyopathy. Next slide. Go back one slide, Simon. There. So here's what I was essentially giving you, that it occurs primarily in Black women, occurs during the last month of pregnancy, up to 5 months after delivery. Older women, high mortality rate. This is really high, 10 to 20% is huge. And I told you about the symptoms already. Heart failure is often diagnosed, and the appropriate treatment is given, as Dr. Reed gave you, Shauna.
Mhm.
The cardiac ejection fraction is under 45% with a dilated heart. And the ICD, that is the implantable cardiac defibrillator, and CRT, that is a pacemaker, which coordinates your cardiac
Your heartbeat.
Beats.
yes, synchrony
Mhm.
between the two ventricles. And finally, heart transplantation can be given. There's an advice that no repeat pregnancy should be undergone for at least 5 years with a normal ejection fraction. My advice is that if a lady develops this condition, she should never get pregnant again, because it could be life-threatening the second time around as well. So that's postpartum or peripartum cardiomyopathy. And I wonder if there are any questions that we should entertain at this point in regards to Shauna's case or any case. Does, Dr. Maxey, do you want to field any questions on this?
We have any questions in the chat, Dr. Walks?
Looking. I do not see questions in the chat at this point.
So what was the actual cause, in a few words, of the cardiomyopathy during pregnancy?
That's exactly what we don't know. There's a lot of speculations, even things like the possibility that this hormone prolactin, which occurs and is increased during the pregnancy, might suddenly be accelerated. The action of it might be increased, and it could have a toxic effect on the myocardium. There are several theories as to why this occurs. Nothing has been really settled on as far as a specific cause is concerned.
So let me jump back in, Dr. Williams. I think everyone was just wrapped in your presentation. As soon as you said, were there any questions? Dr. Gibson put his hand up, and Dr. Khan has a question in the chat. Is it possible that a patient may have several normal pregnancies and then develop cardiomyopathy in a following pregnancy?
Good question, and the answer is yes.
Can
And-
you unmute Dr. Khan for a moment? Dr. Khan, do you want to expand on that question?
Yeah, no, I was just wondering. Hi, by the way, my name is Zafar Khan, and I'm a medical graduate. Dr. Maxey invited me to this forum, and thank you so much. It's a fantastic forum, learning so much. So yeah, I was just wondering if it's possible to develop a cardiomyopathy, because I'm thinking that there's possible autoimmune. It's like it's genetic. There's possible. It could be autoimmune, because it's not obviously it's defined as being idiopathic, and whenever they say cardiomyopathy, then that's what it usually means. What are in the cases that you've seen, have you ever been able to pinpoint specific causes that may have contributed to this condition?
The answer is no. I have not been able to pinpoint them. Actually, like most cardiologists, most doctors, it's the experience with this condition is very sparse. Most of us have not either seen these cases, or if we have, there've been very few. It's not that common a condition, but it's common enough that we have concerns about trying to do something to prevent it. And we're not sure exactly what that should be yet. We have to, first of all, determine what the cause might be. And that's still under investigation.
Well, I
And,
had I'm sorry. I had several miscarriages before this. I've only had the one child, and I had several miscarriages trying to carry a baby. And it took it to this point, and in trying to have that baby, I also, my heart was affected at the same time. But I did have miscarriages prior to.
But this was the only birth that you had. This child, or okay.
Mhm.
As I mentioned early on, this condition tends to occur in patients that we call multiparous, those women who've had multiple births, not necessarily all which are live births. And that may have something to do with the causation. It may be that this toxic entity that is affecting the heart were responsible for that impact on those previous pregnancies.
Did
I'm
give birth
thinking
to a
it's-
stillborn. I gave birth, Dr. Khan, I gave birth to a stillborn prior to the live birth.
Okay. And how many months along was that, if you don't mind me asking?
That was 7 months.
7. Oh wow.
Yeah. So that was 7
So
months.
it's
Yeah.
possible that certain antibodies may have developed in a prior pregnancy, and then
Exactly.
So we had Dr. Gibson had a question and Dr. Sherrod had a question. If we could unmute them.
Thank you very much. I'm really concerned about the Black maternal mortality crisis that we're experiencing right now. And it just doesn't get the exposure that we're experiencing right now because so many Black women are struggling with the challenges of preeclampsia and postpartum complications. So I guess my question directed to you, Dr. Williams, is that when we look at peripartum in particular, is that what you probably or possibly would suspect in those complications that we see in Black women postpartum when they do happen to not survive?
Yes, Dr. Gibson, that's an excellent point. There are many women who have this condition who have suffered preeclampsia and possibly also eclampsia. And perhaps that is a factor in the causation of this cardiomyopathy. Again, the connection is not clear, but more and more evidence is being accumulated that perhaps those are factors. My suspicion is that there are multiple causes, not just one big cause. And I think that will be borne out the more that we're able to study this disorder. To your point about the increased maternal mortality in Black women, there is no question about the fact that Black women suffer 3 times the maternal mortality that white women do. And this is something that is of great concern. You might be aware of the fact that our United States Vice President, Kamala Harris, has taken this under particular consideration in trying to get some federal funding for this. And I also have been apprised of the fact that Drew University here in LA has just received a very large grant to study this particular problem. That is the problem of premature death in Black infants and increased maternal mortality. So it is a big problem. And what we're doing today is focusing on just one aspect of that, and that is the cardiac aspect.
Thank you so much.
Dr. Sherrod?
Yeah, thank you so much. First, I want to commend you, Dr. Williams, on your excellent breakdown of this particular problem. And pretty much many of the comments that I was going to make have already been made. The Association of Black Women Physicians is working also in looking at maternal mortality and infant mortality. It's a major problem. And what I think we need is to figure out how we can bring more attention. We are getting a little bit more through Kamala Harris, our vice president, more money to study and look at these particular issues that are leading to the increased mortality in Black women, Black mothers, and in Black infants. I was just, in regards to the cardiomyopathy, I was just wondering if there have been any studies looking at possible predictors, or what are the common things that will predict or indicators that you should look for this in this particular situation. And I'm really concerned about viral evaluation. Viruses are one of the major causes of cardiomyopathy. And I'm just wondering if there's any data looking at the woman's history of viral infections prior to developing the cardiomyopathy.
Dr. Sherrod, I don't know of any, but you're right on target in regards to looking at various factors. There are some suggestions that maybe even the blood type might be significant in being suggestive of something there. And Dr. Khan has also suggested that perhaps there might be some immunological factors that
Right.
might be, but we simply don't know enough yet.
So I want to get you back to the rest of your presentation, Doctor.
Thank you. If we can have the next slide, I'd like to trip over to the next case of cardiomyopathy and very briefly discuss that, which focuses on what Dr. Maxey just presented early on in the program. Can we have the slides again? So while the slides are being brought up,
Can you
another
put it back on, Simon.
type of cardiomyopathy, which was on that list, was called transthyretin amyloidosis cardiomyopathy. And if you can go back one slide, Simon. Okay, it's about halfway down. You can see it says transthyretin amyloidosis. And in the parenthesis, it says ATTR-CM. ATTR-CM or ATTR-CM is something that we are have increased concern about because of the fact that it is of rather new, I guess you'd say in quotations, new presentation of heart disease, and it disproportionately affects African Americans or Blacks in general. Don't have enough time to talk sufficiently about it, but if we can go back to consider that case that Dr. Maxey presented and move forward on the slides, I'll tell you a little bit more about it. Go back one slide, right there. This is the heart with ATTR-CM, and it shows a normal, healthy heart on the left. I don't know how many people can appreciate what that means. Might look like a piece of steak, but on the right is the heart with ATTR-CM or cardiac amyloidosis. You can obviously see that there's a difference between the two, with the very thickened walls of the heart caused by what we call increased amyloid fibril deposition. Next slide shows a cartoon depicting what this disease is all about. So amyloidosis is caused by this protein that normally circulates in the blood and is produced by the liver. And I'm not going to get too fancy with all of this. The liver normally produces these things that are called tetramers, and they go out and do their job of helping to circulate different things in the circulation. But for some reason, it could be due to aging and some defects that occur from the aging process, or it could be due to genetic causes. This process gets disabled, and there's a dissociation between these tetramers such that there is what we call disfolding and the misfolding, and the misfolding of the fibrils results in deposition of these unusual or abnormal substances being deposited in various organs, including the heart. Next slide. So to cut to the chase on what this disease is all about, there are two types of, actually three types of cardiac amyloidosis. The ATTR type you see here is broken down into what we call the wild type, which predominates mostly in Caucasians and is the most common form. And then there's a hereditary form, which is found mostly in Blacks and is due to the mutation of a particular gene or a couple of genes which lead to this misfolding that I just told you about. The other type is what we call AL amyloidosis, which is due to the deposition of these light chain substances or proteins. And we're not going to talk about that one today. Next slide. Go beyond this because we'll come back to that. Next one. Okay, this is a little bit of the statistics. 7 to 13% of older patients with what we call HuFPEF or heart failure with preserved ejection fraction, don't worry about that term, had the wild type deposits in their heart. That's a pretty high percentage of the general population. But in particular, that's pertinent to this talk today, 3 to 4% of African Americans have what we call a TTR genetic mutation. That is the kind of thing that we find in ATTRCM. And that mutation is called V122 isoleucine. Don't worry about that either. All that means is that there's a genetic defect that occurs due to a mutation in the genetic structure, and it affects, as far as we can tell, at least 1.2 million Blacks who have this disease and don't even know it. And we think that that's just the tip of the iceberg. And some people with aortic stenosis, which is a heart valve disease, undergoing surgery, have been found to have this particular defect. Next, please. So here's some clues to the presence of ATTRCM. Bilateral carpal tunnel syndrome, numbness and tingling in the hands and feet. That's a possible polyneuropathy. Shortness of breath, heart palpitations, and lower back pain, which may be a suggestion that there is spinal stenosis present. Next, please. How is it diagnosed? Usually through initially EKGs and echocardiogram studies. There are certain imaging studies, such as a cardiac magnetic resonance imaging, and also a technetium-99m pyrophosphate scan, or what we call a PYP scan. That's a technical term for a nuclear scan that can be done. There's also genetic testing of certain types that can be done. And finally, a tissue biopsy of the heart, the liver, and maybe a fat pad or something of that sort. Now, all that means is that if we have someone like this gentleman that Dr. Maxey presented, who has symptoms that are suggestive of heart failure, and if those symptoms are treated by especially a cardiologist and are resistant to treatment, one should think about the possibility that ATTRCM might be present, especially if that individual is a Black person, either male or female. And the treatment of the disease is as follows. You start with the treatment of the underlying heart failure, if heart failure is present. And there are several different medications which are being developed or have been developed. I won't go into details about them now, but in any event, there are several which are being developed. There is only one treatment at the present time that is approved by the FDA for the treatment of ATTRCM, and that's made by Pfizer. It's called tafamidis or Vyndaqel. And it doesn't cure the disease. There is no cure at the present time. From the time of diagnosis to the time of the person passing away from this disease, if it's not treated, is about 2.5 to 3 years, no more than that. With treatment, the survival can be extended. There are also some new techniques that are being developed, one that's called CRISPR, which is on the horizon. That's a gene editing technique. And then finally, if the patient qualifies, heart transplantation is a final resort. Liver transplantation is also something that may be done, especially since there may be an attempt made to get rid of the source of the amyloid that is being produced in the liver. So that's the end of my slides on this condition and on these various conditions. I'll stop to answer any questions that you might have or any comments that anyone wants to make.
Any questions
So-
in the chat, Dr. Walks?
So there is an earlier question that Dr. Khan had put in, and I'd like to expand his question a little bit and ask you to react to it, Dr. Williams. First of all, Dr. Williams, every time you come, I feel like I'm back in my first or second year medical school. So thank you. Thank you. I feel so young after you talk. Thank you for that. There's so much, it's so rich. Dr. Khan had asked a question about, are inequalities in healthcare a significant contributor to the increased mortality? And I wanted to just ask you to take that question and clarify one of the things you mentioned earlier. If memory serves, you said that the wild type was the most common, but then you said the hereditary type was most common in African Americans. And I wanted to clarify that when you say the most common, is that related to the fact that there are just more white folks than there are Black folks? Or is the higher, because so many times we hear these kinds of statistics and we think it means that this is more common in a certain group, but maybe it's just because there are more of them and percentages and numbers are sometimes getting a little bit unclear. So
The real question
you
would
could-
be, we're talking global or local?
Well,
We're talking globally and locally. When you say global, you have to consider that amyloidosis, especially affecting the heart, is not necessarily at its maximum in the United States. There are countries like Portugal where ATTR-CM is particularly rampant. In Asia also, and in some other countries of the world. But we have an emerging problem here. We're just starting to recognize and seeing the tip of the iceberg. To answer Dr. Walks's last second question in regards to the wild type versus ATTR-CM or the hereditary form, the wild type is not genetic. It is something that occurs primarily with age. It's found in much older individuals, usually individuals 65 years of age or older, many of whom are in their 80s, and most of them are whites. And that's in contradistinction to the hereditary form, which we're concerned about today, particularly. That seems to affect mostly Blacks, and 99 to 100% of the cases are in Black people. We're not quite sure why that is, but we have to deal with it as it is. As far as where the Black people arise from who get this, most are from the west coast of Africa, as far as their heritage is concerned. And it is found in other areas in the diaspora. For instance, I don't know, well, in any event, I was called by one of our colleagues about a case of ATTR-CM in Jamaica. There's a Jamaican physician who had been diagnosed with it, and I'm a member of Pfizer's advisory board on this disease. So she called me to ask if there was any way, and this pertains to Dr. Khan's question about disparities, whether there was any way that the tafamidis or Vyndaqel treatment could be gotten to this particular gentleman who could not afford to pay for it. And I decided to approach my colleagues at Pfizer to find out about that. And I found out that they said that they did not provide what is called the compassionate treatment protocol to areas outside of the United States. If you don't mind, I'd like for Dr. Lisa Curvin to comment on that because she's the person who referred the case to me. And then I'll finalize what happened with that case. Dr. Lisa Curvin.
Dr. Lisa's is unmuted. Go ahead.
Yes, we do have cases here. Usually they're not treated. That particular patient is a physician friend of mine who would find it very expensive to cover that treatment. What we discuss is we do have Pfizer drugs in Jamaica, but Pfizer did not cover that drug in Jamaica. So Dr. Richard Allen Williams was actually helped us and helped set up for the fact of Pfizer to actually put it on a drug for Jamaica for compassionate use, that anyone who has ATT or amyloidosis of the heart can get access to the drug. Supposedly for free. We have a lot of politics going on also with our government, but supposedly it's coming in for free.
Let me clarify
We're trying to get the other cardiologists to be aware that it's now available, because when we brought it up, their reaction was, we just don't have it, so they don't refer.
Let me clarify.
Thanks again, Dr. Williams.
Dr. Curvin, let me clarify a little bit of what you're saying. So this was a Jamaican doctor who had been diagnosed with the disease, and you referred him to me, or at least the case to me, to see if we could get some compassionate use funding or consideration for him to be able to get the drug. Let me point out the fact that the drug is extremely expensive. It costs, get this, about $250,000 a year for one patient to be treated with that drug. $250K. Most people can't afford that, of course. And even if they could, that's a damnable amount. But in any event, what I did was to present this case to Pfizer and ask them, would you give this patient some consideration? And they said, after a couple of weeks of thinking about it, yes, even though we don't usually give compassionate use consideration outside of the United States, we will do that for him. And then they asked me if that was enough. And I said, no. They said, why not? And I said, well, because there are other people in Jamaica and other countries who qualify for this and can't afford to pay for it. And this gets back to Dr. Khan's question about disparities and so forth. So I said, I think you need to give compassionate use to all of the people in that country. And they said, well, let's think about it. That, we're in the business to make money, not to necessarily be generous with our treatment. And so I went back, and after 2 weeks, they said that they were going to exempt anybody in the entire country of Jamaica from having to pay for the drug at the regular rate.
So, Dr. Williams, let me go to the heart of the matter. On
Yes,
a
sir.
cost basis, what would it cost Pfizer to make a dose of that drug versus what they commercially sell it for? What's that relationship?
Oh, pennies to dollars. There's no question about it. It doesn't cost.
It has to be,
but
because
it has to do with more than that. That it takes basically 18 years, and they'll tell you this, to produce a drug from start of their R&D to finish. and they calculate the cost of that R&D into the cost of the drug.
There was another drug called Bideal, which is made out of two of the cheapest substances there are, and they sell that for 100 times what it's worth.
So
1,000.
Dr. Maxey, let me not press Dr. Williams' disclosure. Dr. Williams is 100% accurate that yes, the drugs can usually be made for a lot less than that amount for which they are sold. And it is true that the companies are in business to make money. And it is true that they spend a lot of money developing drugs. I don't have any Pfizer disclosures. They do spend a lot of money making drugs, and they do try to recoup some of that money in the cost of the drug. So it's not that they come up with some, and because we have a non-physician audience to some extent, it's not, you can think they're bad if you want to, but it's not only because they come up with something cheap and want to charge you $1 million for it. That's not the entire story. So let me just put that on there.
Well, the other part of that, Dr. Walks, is that other countries do not pay what the United States pays. So
That's a United States government issue. And
Yes.
I have been involved in that over the years with the government deciding not to negotiate drug prices like other countries do. That's a whole nother show, Dr. Maxey. When are we going to do
Can
a Black Health Trust on that one?
But
Maybe
suffice it to say that
another week.
President Biden has just taken that on.
Yep.
And he's formed this hit list of 10 initial drugs.
Yep.
That he's going after and their manufacturers to try to get a reduction in drug prices and so forth.
I can say something though. While Dr. Williams was negotiating this for us, which took a couple months, we actually sourced the drug in India. Now, I don't know, one of the comments was we don't know how close it is to the real one, but the cost to bring it from India to Jamaica would have been $3,000 a month US. So markedly cheaper. The question that we came up with was, how do we know we're getting the real thing? But they said they were, and it seemed like it was, and it would have been 3,000 US a month, which is a big difference.
Well,
Wow.
India does some of the major manufacturing of most of our drugs, I understand. So,
Correct.
so you're
Correct. And they said they were the ones making some of Pfizer's. Don't know if it's true or not.
It is true. It is true. Are there any other questions, Dr. Walks, in the chat?
There's one question that should be very easy, and the question is, well, should be, Simon, there's a question from Dr. Sherrod. If we could put up the slide again that has the ATTM-CR symptoms, because it is important to be able to know what the symptoms are so we know what questions to ask the doctor. And then another question from one of our regular attendees, Linda Minter, was if Sjögren's syndrome symptoms can we look at the difference between the ATTR and Sjögren's syndrome?
Okay, there's
If there's a difference between being tired and having having the ATTR, or being tired and having the Sjögren's syndrome.
Can you see the slides now?
I can. I think that if I'm correct, they're referring to Sjögren's syndrome, which is the dry eye syndrome. Is that correct?
Yes.
Okay. That's an immune type of syndrome, which may or may not play into this whole thing. To my knowledge, it really does not, although there may be cases that do.
So
Well,
explain carpal tunnel syndrome, if you would.
Let me just clarify, if the question specifically is about the tiredness that is a side effect of the Sjögren's syndrome, as opposed to tiredness versus an issue with the heart. And I'll just say, as a non-cardiologist, there are a lot of things that can give you a symptom of being tired.
Exactly right. And that's the answer that I would give to that.
Would you comment on the carpal tunnel syndrome?
Okay, carpal tunnel syndrome, which may or may not be bilateral, is a situation in which the wrists, the bands, so to speak, around the wrist of connective tissue, of ligaments, so to speak, become inflamed. Now, many people say, well, maybe I'm typing too much or using my hands to wring out the clothes too much and causing this irritation in my wrists. And that's called carpal tunnel syndrome. That the carpus is the wrist, and the fibrous structures that surround the wrist, and there is a tunnel through that carpus, which gets narrowed and leads to pain because of the pressure that it exerts on the nerves that go through there. And that's called carpal tunnel syndrome.
So that's
And this is a question, Dr. Maxey, that Dr. Sherrod put in to ask for the slide to be put back up, and she has her hand up again. So I know we're getting close to the end, but Dr. Sherrod has that special relationship with Dr. Williams, so we don't want to mess with that.
That's Sherrod. Go ahead.
She's muted.
Oh, okay. Yeah, my question was, what stood out for me was the bilateral carpal tunnel syndrome. I'm really just trying to figure out, is there something that would kind of key you off to, okay, we need to look for this ATTR-CM, because obviously it's been missed for many, many years, right, Dr. Williams?
Yes.
And so how often do you see bilateral carpal tunnel syndrome?
50%.
50%?
of cases, yes. Not all of them, but about
But
half.
if somebody has that, then I think that's an automatic part of the differential diagnosis.
That's a red
Anybody
flag.
with bilateral carpal tunnel syndrome, of
So
course,
that-
fatigue and all of that, there are just so many things with fatigue. But if you have somebody with bilateral carpal tunnel syndrome and fatigue and the polyneuropathy, I think you need to work them up.
Well,
Thank you
Dr.
so much for making that point. That's an essential point.
We had several seminars on this for physicians in general that Dr. Williams put on across the country. And with this list of things that we're asking our primary care doctors to look for, to refer them to a cardiologist for further diagnosis. And this, you're exactly right.
Great.
And to get back to Dr. Khan's point about differences in care and approaches and so forth, that tracks all the way back actually to even the drug company. I had an issue with Pfizer that I'll tell you about, and I'm not talking out of school. I was one of the first people to be on their program to increase awareness about this disease among Black people. And we organized a program which Dr. Maxey took part in, which is called Voices for the Heart. And it was broadcast and still is being broadcast around the country. In conjunction to that, they started an advertising or publicity program with commercials on TV that many of you may have seen. The commercials on ATTR-CM. The commercials initially came out with white people in the roles of those who were suffering from the disease. So I immediately contacted Pfizer and I said, hey, wait a minute. We're talking about disease that affects primarily Black people, and you got white actors in those roles. And they said, oh, well, we're aware of that we have to make sure that everybody is aware of this. They were particularly concerned about the large number of people who also have ATTR-CM, who have the wild type, who are mainly white, as I mentioned before, not the ones who have the hereditary type of ATTR-CM, who are almost universally Black. And so with my complaint, they decided to go back to the drawing board. And if you look now, if you see the commercials, you'll see some Black actors in there.
So that's marketing and profit. Well, we're at the top of the hour, and Dr. Williams, why don't you take a couple of seconds and give final comments, and then Dr. Walks and I.
Well, my final comment is that I came on this program, this wonderful program, which is designed to raise awareness about various issues affecting our health among Black people in particular. And I want to make sure that the message gets home that we have to look at our own health problems as being things that we need to take control of ourselves and insist on the proper care that needs to be designated for it. And that's exactly what we did when we started the ABC, the Association of Black Cardiologists, because as I mentioned, there were wrong conceptions and ideas about health as it applies to Blacks. That's the reason that I wrote the textbook of Black-related diseases, which Dr. Maxey contributed to. And so in the final analysis, we have to be responsible for our own health and make sure that nobody is overlooking the problems that we have, and make certain that people like Shauna are given the proper consideration for the kind of treatment that they need. Shauna might not have gotten the proper consideration if it hadn't been for the fact that Dr. Reed, for instance, was in one of the initial people on the scene in treating her condition. She might have been thrown under the bus, so to speak. And so it's important for us to keep an eye on our own health, and the Black Health Trust is definitely helping with that process.
Well, thank you very much, Dr. And Ms. Porter, just give us a few seconds of what you're doing with your life now that you got a new heart, real quick.
What I'm doing now is I have an organization for a sports youth organization. And so I take care of the babies as far as mentoring, and we do football, basketball, baseball, soccer. And I also feed a lot of families because unfortunately, when you have a lot of children that's out in the community that don't have a lot of things that are going, the families are affected too. So basically, I'm just giving back to the community and doing all I can because, you know, when I was 30, I had to live as I was 80. So now I'm 59, I can live like I'm 30 and everything else. So I'm reliving life again and doing what I would have done earlier in life.
That's called paying it forward.
That's exactly what it is. Yeah.
And don't step in any more holes on the football field.
I know, because I'm out there running around with them. I could never run around and do anything with my daughter. Now I can pay it, like you say, pay it forward, and I can deal with the little 5 and 6 year olds all the way up until 15.
Do you have a phone number you want to give in case anybody wants to know more about your program?
Sure. My phone number is 310-345-7424. And the name of the organization is Cali Blessed Running Wolves. And the wolf represents that strength, you know, and in order to do what they do, and it's a family, it's a pack. Fighters.
Thank you very much.
Thank you.
Folks, how are you, sir?
Thank you, Dr. Maxey. Ms. Shauna, if you could, while I'm talking my mouth, running my mouth, don't listen, just type in the information about your organization and the contact so folks can contact you and they can support what you're doing. There is so much. As I said earlier, Dr. Maxey, when Dr. Williams comes on, there's a lot. As we were going through those slides, I'd like to ask Dr. Williams to come back and take us through all the slides he didn't take us through today. There's a lot of stuff in there that I think would be absolutely useful. One of my favorite words, absolutely useful for us to find ourselves exposed to. I think that, and Dr. Maxey, as we talk about in church sometimes, the power of the invitation, inviting Dr. Khan, the additions that he made to our meeting today, because some of the questions that we take for granted, in particular, the question Dr. Khan asked about the inequalities of healthcare possibly contributing, do those contribute when we were talking about the mortality rate in Black moms? We need to talk about that, and we need folks to ask those questions because I think maybe some of us think everybody knows that. And of course, but no, we need to continue talking about that. I think one thing that we didn't get a chance to really dig into a lot is what happened and what was Shauna experiencing between the birth of her daughter and that heart attack. Because if all of us need to have a heart attack in Dr. Maxey's office with doctors that know Dr. Williams and he respects in order to survive to age 59, a lot of us are not going to make it. There is so much in our community that really depends on us being in the right place at the right, and it shouldn't be like that. We should be able to have no inequities. We should be able to get good care every place we go to get care. And I think as long as that's not true, we don't have that trusted primary care person that Dr. Jordan always talked with us about, how important that was. It's critical for us to do that. So the power of the invitation, the taking seriously the symptoms that folks come to us with, no matter what they look like, no matter what they sound like, no matter how uneducated or educated there may be, all of those things matter a lot. And I think they all play into what Dr. Williams shares with us, because again, it's useful. We need to know that things are equal. And so, Dr. Williams, thank you. Thank you, man. Always appreciate you. Shauna, thank you for allowing us to feel a little bit of what it's like to go through what you went through. And the last thing I'll thank you for is that statement about faith. It is a wonderful thing, and backed up by Dr. Williams' expertise, that when we come to an opportunity / challenge with our faith solid, the doctor's job is a little bit different.
That's right.
Faith and fight. So
That's right.
That's the first 5 minutes of my presentation, Dr. Maxey. I'll continue another time.
Thank you, Dr. And since you mentioned it, Dr. Khan, are you still on?
He's still on. He's on mute.
If you unmute him for a minute, in 30 seconds, Dr. Khan, can you just tell him about the project we have with Dr. Brown that we're doing for senior patients?
Yes, so we are doing a health assessment or a mental health assessment programs, and basically what we do is a neuropsychological assessment where we go. I don't know if you guys have heard of the BCAT. Anyone here heard of BCAT? No.
No.
Well, it basically assesses things like learning, memory, attention, the patient's ability to problem solve and those kinds of things. And just to see where they are, if there's any problems in those areas, in different ways we can address them. And that's just one part of the program. We use that to assess the patients. And then what we have planned in the works is to do EEG testing, or basically brain mapping, and then follow that up with neurofeedback.
Okay, well, thank you.
To help those patients with different kinds of needs, whether it's depression, anxiety, or memory issues, a whole lot of things.
Well, thank you so much. And that's going to be very useful. Anybody who wants to know more about that, contact me. And you can reach me through my number at 310-849-4331. And Dr. Lawson is one of our team members on that. I thank everybody for their day on this Sunday. Thank you for your faith and what you heard. And thank you, Dr. Williams. Thank you, Ms. Porter. Everybody have a great, great day. And thank you very much, Simon.
Thank you all.
Thanks for a great program, Dr. Maxey and Dr. Walks.
Thank you.